Delivered by Sally Abbott, who is a nurse colposcopist, hope I pronounced that correctly, at Doncaster and Bassetlaw NHS Foundation Trust. My name is Caroline Brannigan. I'm the Head of Health and Wellbeing on the Network Committee. Liz Leggett and Sarah Cook from the committee are also supporting the session today. Just a quick background about the network, if you're not familiar with it or if you're not already a member. So South Yorkshire Women Inspired Network exists to inspire, empower and elevate women from all backgrounds to reach their full potential. The network offers a dedicated space where women can connect, lead and thrive, supported by mentorship, shared learning and leadership development tailored to their lived experiences. We offer regular webinars, courses, inspirational talks and events, as well as career mentoring and other offers. We'll pop a link in the chat, for our link tree, which contains all of the main links, including the website, a form to join the network if you're not already a member, and our social media pages, which we post on regularly. The session will be recorded and slides will be added to the Women's Network website, and also we'll share the slides in a follow-up email afterwards. If I could ask you all to remain on mute during the session, and if you've got any questions for Sally, there'll be plenty of time at the end to answer those, so you can pop them in the chat throughout, or you can ask them at the end of the session. So now I'd like to introduce Sally. Thank you.
Thank you, Caroline. Can you all hear me? Is that you? Yeah, just give me a nod. Yeah, perfect. Okay. So as Caroline said, my name's Sally Abbott. I'm the lead colposcopist at Doncaster and Bassetlaw NHS Foundation Trust, and I'm a nurse by background. I've been asked to talk to you today around the subject of cervical health, and I just want to reassure you all that it's a very open and non-judgmental session. You're in a safe place to ask lots of questions, and I'm really hopeful that we'll get a little bit of discussion at the end of the session, at the end of my slides. So if you do have any questions, if I could ask, as Caroline said, just jot them down and we'll have plenty of time at the end. I'm very well aware that we all probably come from different backgrounds, both professionally and personally. So I'm hopeful that the slides of the presentation I'm going to do will kind of touch a bit of everything. But please bear with me if it is a little bit over your head, and hopefully I will explain some of the slides as you know, in a bit more detail, and you'll understand it as we go along. So if we could just move on to the next slide, it just shows you and again, sorry, that was just a welcome. So just a little bit of the content about the things that I'm going to discuss. So we'll talk about cervical screening and the human papilloma virus. We'll just discuss sample taking and what the future could potentially look like. I'll then talk about colposcopy and a little bit about cervical cancer. And then we'll move on to the normal physiological findings. And then, as we've said, hopefully have time at the end, or we will have time at the end for question and open discussion. So the cervical screening programme, the aim of the programme is to reduce the number of women who develop cervical cancer and reduce the number of women who die from cervical cancer. And it does this by offering regular screening to all people with a cervix at risk, who are at risk, so that the condition which otherwise might develop into cancer can be identified and treated at the earliest opportunity. So the next slide just runs through the history of cervical screening. So smears, I guess the vast majority of them probably still refer them to as smears, were introduced in England in 1964. Initially, it was very disorganized and it was very much opportunistic. So if you went along to your GP with symptoms, they may or may not take a sample. But in 1988, the NHS screening programme was introduced, and along with that, the call and recall system. So that's what we know now of when we can receive, it used to be a letter, but now the vast majority of the invites are going through the NHS app to go along and have your screening sample taken. In 2004, we introduced a liquid-based cytology, and this reduced the number of inadequate samples. So historically, it used to be, and this is where the smear terminology comes from, it was just a sample taken from the cervix, which was smeared onto a glass kind of slide, if you like, and then that was put into preparation and sent to the laboratory. And then in 2004, they introduced the liquid that we now use to this day, where we take the sample with a brush and then transfer that sample into the liquid, and then that fixes it. And as I've said, it reduces the number of inadequate samples and just makes for a much more sensitive and specific sampling. In 2024, we started to introduce the HPV element of the test. So this was when HPV sampling was first introduced, and it was introduced to a select number of samples. So not everyone was HPV tested. It was more for patients that had an abnormal sample when they looked at that sample slide, or for patients that were having what we call the test of cure. So that's the sample that's taken 6 months after their treatment. And then in 2019, we introduced primary HPV testing. So this is when all samples were tested for HPV in the first instance. So patients would go along for their sample to be taken. It was then sent to the laboratory, and when it hit the laboratory, they automatically look for HPV in the first instance. If it tested for HPV, they then looked at the cell element, but if it was HPV negative, the patient was then put onto the next screening interval. So if we move on to the next slide, this is just a picture of the kit that we use. So I mentioned the liquid that's in the pot, and then this is the brush that we use now. Historically, women were tested from the age of 24 and a half up to 50 every 3 years, and then from 50 up to 65 it was 5 yearly. But from the 1st of July last year, so the 1st of July 2025, we moved to a 5 yearly screening programme for everyone in England. Scotland and Wales went to that regime a while ago. Scotland quite a few years ago, and Wales I think was just in 2020, but England went last year. But if anyone is on, so that they wouldn't change people's screening intervals in retrospect. So for example, if you'd had your sample taken pre-July 2025 and you were on a 3-yearly screening pathway, you will have that in the 3 years as it was directed, and then thereafter you would change to 5 yearly. So you can see on the screen there, these are the uptake figures. They are quite dated, but the trend is pretty much the same. 5 million women were invited each year for screening, and 1 in 4 do not attend. And some of the age brackets, as you can see there, that rises to 1 in 3. And we've just given you some figures there for Doncaster and for South Yorkshire as well. And I would anticipate that those figures are actually sadly declining.
Right, okay. And I just saw it a moment ago there. Right, how do I make this bigger?
So if we just move on to the next slide. If we can, this just looks at some of the reasons why those figures may be declining. There is still a big embarrassment around about screening. I guess there always will be. And I think as we move forward, I think people are talking about it a lot more. And I think there are a lot more conversations going on within friendship groups and, you know, friends at work and with families, but there is still that element of embarrassment. People do still struggle to get time out of their employment to go and have that sample taken, and not only with their employment, with their busy lives with children. I think things are improving, and I think there are appointments that are being offered out with the conventional 9 till 5, but I still feel that this is an element that stops people going for that screening sample. Again, people are worried about pain and discomfort. They've potentially had a bad experience, trauma in the past. And I find I see predominantly women in the colposcopy clinic who have had an abnormal smear result. And I think a big fear for people is that result. So they don't really mind going for their sample, but they're terrified that they will have an abnormal result and what will happen after that. And it seems a bit kind of strange to say that, but I genuinely think that that is an issue. There still seems to be a big stigma attached to screening, and HPV and cervical cancer it's significantly better than it used to be many years ago, but I do still think that people do still kind of think that there's a link between HPV and potentially that sexual transmission element of it. People don't think they're at risk. And a lot, we do still get people that are unaware of the screening program, sadly, and that tends to be people that have come in from abroad. And there are still a number of patients that aren't registered with GPs, so don't have access to it. We just move forward onto the next slide. We'll move on to talk about the human papilloma virus. So this, as I've said earlier, is what we test for now. So the HPV is a double-stranded DNA virus. There are over 200 strains of it out there. The vast majority of those we pass on through skin-to-skin contact. So me shaking someone's hand, kind of touching their arm, we will pass HPV on. But most of them don't cause any problems whatsoever, and we don't know we've got it. There's a small number that cause annoying problems like verrucas, cold sores, and genital warts. And then there's another group, around about 14, that we test for when we do the cervical screening. And it's the only way they can really come in contact with this type of HPV is through sexual contact. So it doesn't have to be intercourse, it can just be touch, and it can be the use of sex toys or oral sex as well. And normally what would happen is you would come in contact with HPV every time you have a new sexual partner, and your immune system would clear that virus. But if your immune system's struggling for whatever reason, and that could be your past medical history of autoimmune conditions, or if you take any autoimmune kind of steroid medication, or if you smoke, your body will hold on to it, and it doesn't always, but it can lead to problems. So that HPV can cause problems and cause cell changes. And it's felt that 79 million people throughout the world are infected by HPV at any one given time. So if we just move on, you should see, yep, there we are. So that's kind of a picture on your left of the genital, the human, the female kind of genital tract there. You can see the ovaries, fallopian tubes, and then the cervix. And then if you look onto the other side, that's you, as I would see the cervix looking at the patient. And the reason why the cervix is so affected is because the cells undergo change. So when we move into puberty, the glandular cells that are once tucked up inside the cervix come out onto the surface of the cervix, and the pH balance with the vaginal discharge will cause those cells to undergo metaplasia. And because of the cell changes that they're undergoing, that HPV can infiltrate into them. So if we just move on to the next slide, that looks at other areas that can be affected, just for your information about with this HPV virus. So the cervix is predominantly the area that's affected, but you can also get problems to the vagina and the vulva, and the anal area as well can be affected by it, but also penile cancers, and there's a lot of research now coming out with regard to head and neck cancer and stomach cancer, all driven by HPV. So the next slide looks at the HPV vaccination programme. So this commenced in 2008. At the time, all girls in year 8, so between the ages of 12 and 13, were offered the HPV vaccination, and that was part of the adolescent vaccination programme. Initially, the vaccine offered protection against 2 strains of HPV, and they were notably 16 and 18, and they caused 70% of cervical cancers. And the programme involved having, in the early days, 3 vaccines. So we did get a lot of girls that dropped out, maybe they only had the first one, they didn't have the second or third. So it was felt that they weren't fully vaccinated. As time moved on, that vaccine changed, and it now protects, it then protected against 4 strains. So the 2 that were added in were protecting against genital warts. And then since 2019, boys have been included, and we now protect against 9 strains of HPV, so 7 that affect the cervix and 2 for genital warts, and it's in 1 dose only. So we're hoping that this will improve the uptake. and also including the boys, they'll get the protection against penile cancer and head and neck and stomach cancer, but also it offers that herd immunity as well. So we'll just move on. So this just looks at the future. I guess we hope that the vaccine will develop as well, and it'll in time it will cover all strains of HPV that we test for. So as I said, we're testing for 14 at the moment. We're also looking at self-sampling, and in the not too distant future, I believe in the next we could be talking weeks, they will bring out self-sampling. So in the early days, that won't cover everyone. They will very much look at underscreened people. So people that they can identify that have defaulted from the screening program will be sent a self-test sample kit out to their home with the hope that they will then complete that and send that back. I guess the only slight concern about that is that it will only be able to identify whether or not the HPV virus is there. So if it is there, it will then require the patient to access a clinician taken sample so that we can look at the cells. But hopefully that, it may kind of encourage people to come forward, and then obviously if they do know they've got HPV, it may encourage them to go for that clinician taken sample. They've done a lot of work around the digital communication. So initially the call and recall was put onto NHS, the NHS app. So people are getting their notifications via the app. If they don't open that notification within 48 hours, they will be sent the normal letter that we were all used to receiving. Digital communication for negative results. So if you go for your sample, it's normal, you will then get notified via the NHS app. And again, if that isn't open within 48 hours, a standard letter will go out to you. And that will only increase in terms of the catchment for that. So patients who have abnormal screening results will then in time be notified of the results via the NHS app. They've then looked at the transgender and non-binary group of patients. There was issues with patients that changed their gender on the NHS system. So their NHS number was linked to their gender. And if they were put down as a male, but still having their cervix, they wouldn't be called. So now if patients do still have a cervix in situ, they can opt in and still be called as part of the screening programme. And as I've talked about earlier, from January the 1st of last year, the screening programme went to 5 yearly for all. And our knowledge for HPV is increasing all the time. And I expect, in years to come, we'll have much more information available about HPV and potentially even something that we can offer, because at the moment there is no treatment. But I anticipate in the years to come, we'll be able to identify what we can do to help patients clear that virus, and I'll potentially be out of a job. But hey ho, that's fine. So out of the 100 patients that present for screening, 87 of them will have a HPV negative result, and they'll go back to, that's an old slide, 5 yearly screening. Out of the 100, 13 of them will test positive. And then when they look at the cell element of that, 9 of them the cells will be normal. So they'll be asked to go back a year later for another specimen at the GPs, another sample at the GPs, with the hope that over that 12 months, they've cleared the virus. And 4 of them will have cell changes. So that will trigger a referral up to colposcopy for myself in our area or one of my colleagues to review. And then that just brings us on to talk about colposcopy. So it's a medical diagnostic procedure used to visually examine the cervix and the vagina and the vulva as well. So in my service, we see referrals coming in from the main referral source is 2 different types of referrals. So direct referrals from our laboratory is Gateshead. So that's any person that's been to the GP or had a sample taken that showed that they've got HPV and cell changes will come directly to us. or patients that have gone to their GPs and reported symptoms, for example, bleeding after intercourse, discharge, pain, or the GP can't find the cervix to take the sample, they will come into our colposcopy service. So on to the next slide, there's a cervix, and that just shows you what we look at when we examine the patients. So we will identify the cervix using the speculum that they use when you have your sample taken at the GPs. We use metal, which puts people off a little bit. It is a little bit colder, but I actually find patients do tend to tolerate it a little bit better. And it's just because of the high intensity light that we use, we get a little bit of better view of the cervix. We then put acetic acid, which is diluted vinegar, on the cervix. So it's very cold, can be very stingy. And that will, over a period of 2 minutes, that will help us identify if there are any areas of changes on the cervix. So what the vinegar does is it coagulates with protein. So if a cell is abnormal, there'll be a higher level of protein. So when you put the vinegar on, it will go white, like egg white. So you can see there, it's clearly marked A and B. So they're areas of changes that, depending on the patient's history, we may want to do some biopsies on. So we would perform cervical punch biopsies, which is where we take a tiny little nip of skin from those areas that are highlighted, and then we stop the bleeding with the chemical pencil stick. Now, we don't tend to use anaesthetic when we take biopsies, because the anaesthetic itself is can be worse than the actual biopsy. But we've got various different tips and tricks that we can use to kind of distract the patient and make that biopsy kind of a little bit easier for the patients. But it does hurt, uncomfortable rather than hurt, I would say, but it's more the little chemical pencil stick that we use to stop the bleeding that gives that cramping discomfort. We then would wait for the result of the biopsy to come back to decide on whether or not we need to do any more treatment. And that treatment could involve cold coagulation or the loop excision of the transformation zone, which we abbreviate as a LET. So cold coagulation is where we use a heated probe onto the cervix to eradicate that area, so burn that area away. And the loop excision is where we put a little bit of local anaesthetic round the neck of the womb, and then scoop that area away. So that's called, it's an excisional biopsy. And then following that, the vast majority of people would go back to their GP for a smear test 6 months later to check that their immune system has cleared the virus and things have gone back to normal. We do get a lot of patients that don't go for that smear test because they think that the treatment that we've done has cured them, but we need that follow-up sample to double check that. And because someone's had abnormality in the past, there are very slightly higher risk of abnormality in the future, so about 3 to 5% more likely to have abnormality. So it is really, really important that they have that done. I've just put the polypectomy on there. So that's if someone has a polyp, which is a benign skin tag on their cervix, we can remove that as well. And I think later on in the presentation, there are some slides that will reflect that. And we just spend a lot of time reassuring and supporting the patient. I'm very lucky in colposcopy that we have additional nurses in the room to offer what we call local vocals. So they will talk the patient, talk, distract them, and I get on with what I need to do. And normally at the end of it, they'll say, oh, is that it? Because we've distracted them so much. So if we just look at the next slide, this just shows you a little bit. It's basically the change in the cells. So if you can see on the left-hand side, that's a normal cell. And then you can see as we go on, the changes over time if this HPV does infiltrate into the tissue. So the initial, if it's just the first basal layer, we call it CIN1, and then that increases as the basal layer gets infiltrated, so CIN2 and CIN3. So the CIN1, we very much hope will go back to normal of its own accord over a period of time. And we tend to just review patients annually, and it can take 2 to 3 years to regress. And depending on that person's past medical history, they may live with that for the rest of their days if they've got something that's suppressing their immune system. And it's just a case of ensuring that that doesn't progress into CIN2 or CIN3. Now, they're more the high grade changes, which could, don't always, but could turn into a cancer. And as you can see, the very last is an invasive cancer. More as we learn more and more about HPV and CIN, we are starting to manage some of the CIN2 cases conservatively. So historically, anyone with CIN2 or CIN3, we would offer treatment for. But now, as research is coming out, we are finding that some CIN2 cases will regress. It does involve close review, so patients have to commit to coming back to clinic every 6 months, and it can take up to 2 years. And at the end of it, if it hasn't regressed after the 2 years, or it worsens during the follow-up, we would offer treatment. But that goes hand in hand with the vaccination program. So if we know someone's vaccinated against the high risk strains of HPV that we know cause problems, then we know they've got a good immunity. So we are more inclined to keep an eye on them by closer monitoring with the hope it will regress. So if we just look at the next slide, we've moved on now to talk about cervical cancer. So there's just a few figures there. So 800 people are losing their lives still every year to cervical cancer, and it's the 4th most common cancer in women globally. It affects mostly between the ages of 30 and 35, and it's very, very rare. It's not unheard of, but it's very rare to come across it in the under 25s. And 99% of cervical cancers are caused by HPV, which is why the early detection through screening, we should be able to diagnose it and treat the condition before it gets anywhere near cervical cancer. There's just the slide there we've just put on regarding the different types of treatment that are available if it hasn't been detected at the early stages of CIN2, and the patient comes in with a cancer. We can still treat it in the form of a loop excision. If it's caught and it's early, we can remove it with that loop. Sometimes we have to progress to 2 loops to check that the margins are clear and that there's no skip lesions. But if it's gone that little bit further, we would discuss hysterectomy, chemotherapy, radiotherapy, and brachytherapy. But now there's a lot more target medicines and immunotherapy coming out as well. So there are definitely treatment options available if it's caught and it's too late for us to do anything in colposcopy. And the future of cervical cancer: in November 2023, the NHS pledged to eliminate cervical cancer by 2040. It's an ambitious task, but by improving the HPV vaccination and screening uptake, they hope that cervical cancer will be a thing of the past. That's a really, really positive thing. So we do get a lot of ladies referred up through their GPs, and when we examine them, we are finding normal physiological findings. So I've just listed a few of them, and I think on the next few slides, there will be a few pictures. So if we just move on to the next slide, it'll talk about each of these in turn. But this is what we call a cervical ectopy. So the vast majority of women in reproductive years will have a cervical ectopy or an eversion or tropium, all different types of words that we've been using over the years. We try to move away from an erosion, which is a word that they used to use, or a lesion, because that's very, very kind of negative. It kind of denote, you kind of feel that it's abnormal, but this is a very, very normal finding. And if you examined 10 patients, 8 of them would have an element of this. So just very briefly, your cervix is made up of 2 different types of cells, as you can see on the left-hand side quite clearly. You've got the squamous cells on the outside of the cervix, and they're very much like the cells on your face. So they're very tough, and they're very smooth. And then inside your cervix, you've got more fragile, friable cells, like the cells in your mouth. And when we go through, so initially, pre-puberty, those cells are tucked up inside. And then when our body starts to release our estrogen, when we go through puberty, those cells will come out onto the surface and they avert basically. And that's when you get that reddened area appearing. Now, those cells are only one cell thick, like the cells in your mouth. So they're very fragile and friable. And that's why they give this reddened appearance. If you have additional estrogen in your body, you will have more of a pronounced ectopy. So if you're taking the estrogen contraceptive pill or you're pregnant, that ectopy tends to be a little bit more prominent, but it's not abnormal. And 9 times out of 10, we don't need to do anything about it. It can cause bleeding. So it can cause you to have bleeding after intercourse, because when those cells are knocked, because they're very friable and fragile, they will bleed. So a little bit like when you knock your mouth with the toothbrush, but it wouldn't give you irregular bleeding. So I get a lot of ladies that are referred up to me who have irregular bleeding throughout their cycle. But when you question them, they're on either progesterone only pill or you know, it's more of a hormonal element rather than anything going on with the cervix. But as soon as the GP sees this, they'll send them to colposcopy thinking that that's what's causing it. But actually, when we examine them, because we're prodding and poking at the cervix, if it's going to cause that bleeding, it would bleed. So it normally needs trauma to it to give the bleeding. But we don't tend to do anything about it. We leave that well alone. When the patient will go through menopause, their estrogen levels will naturally fall, and that will then retract back up inside. You can burn, for want of a better description, those cells with that probe, like the cold coagulation I spoke about earlier. And what that will do is it will burn the top layer a little bit deeper, with the hope that when that heals, the cells will come back a little bit tougher, a little bit like when you burn your arm on the grill or your hair straighteners. It comes back tougher, with the hope that it would stop the bleeding after intercourse. It doesn't have a great success rate. It tends to only work in about 50% of cases because it will just come back. But if that bleeding after intercourse is causing great distress to the patient, that's what we can try and do. So I think the next page, the next slide is looking at something called the Bothian follicles. So you can see there little yellow spots on the cervix. So the cervix has got lots of glands in it. And when it's undergoing metaplasia, like I spoke about earlier, those glands can get covered over. But the glands continue to secrete mucus. So you end up with little spots on your cervix, as you can see there. Now, some people don't have any. Other people have multiple, and other people just have 1 or 2. They're normal. We don't do anything about them. We leave them well alone. Occasionally, if a patient's been referred up and they've got kind of a large Bothian follicle that's potentially obscuring the area that we need to take that screening sample from, we will take a biopsy from it, for the simple reason that that will collapse it, almost like squeezing a spot, again, for better description. It removes the fluid that's inside it, and hopefully it won't return, but there is a bit of a recurrence rate to that. They might come back when that kind of heals over. So it's very much like a spot on your cervix. The only difference is it's sterile, so it's not infected, and we leave them well alone. The next slide shows what we call a post-treatment rosette. So if someone's had a treatment for abnormal cells, it doesn't always, but it can heal like the picture you can see on the right-hand side. So it's just exposing those glandular cells that are inside the cervix. So the picture on the left is just that loop that we use. And then the one in the middle is just once we've stopped the bleeding. And then the one on the right is when it's healed. People heal very differently. I've had ladies back to clinic, patients back to clinic, and you can't even tell they've had a treatment. And others have a very distinctive, what we call post-treatment rosette. So it's puckered, like a rosette, the inside of a rosette. But again, it's all normal and we don't do anything about it. The next slide looks at something called atrophy. So that is when the cervix has become very atrophic, and it tends to happen in the older age group. So as your estrogen levels fall as you go through the menopause, the estrogen is what gives the tissue the elasticity. So it makes everything very flexible. and very supple. But when your estrogen levels fall, the tissue becomes very dry and very much like tissue paper. So you can see that that area we spoke about that used to be on the outside during your reproductive years has gone back up inside. You can see that on the slide on the left and in the middle. And you can see the effect that the lack of estrogen has on the skin and how it becomes very, very brittle, and it can cause a lot of bleeding. And that can give patients a lot of discomfort during intercourse, but also when they're having their sample taken. And as we're now up screening up to the age of 65 and beyond, if people are testing positive for HPV, it can cause quite distress for the patient if it's so uncomfortable. We can prescribe estrogen pessaries to the patient to try and put that little bit of estrogen back into the vagina, into the skin, but we have to be very careful if they've got any past medical history that would counter-indicate that. But there are things that we can do to try and reduce that, because I mean it just looks sore, doesn't it? And then the last slide, it just looks at polyps. So I mentioned those earlier. So these are kind of benign skin tags that can form on the cervix. So they can be quite large. I've seen ladies that come in and they've got, you know, the big strawberries that you see nowadays in the supermarket, you know, as big as that we can remove quite quickly and easily in outpatients, down to tiny, tiny little polyps that you can hardly even see, like the tip of your pen. And we just kind of twist them away. They come away really easily, a little bit of cramping discomfort, and then we stop the bleeding with that little chemical pencil stick. And the vast majority of them are normal, benign. We send them away to the laboratory just for completeness, but they tend to be nothing to worry about. They can give people bleeding after intercourse when they're knocked, because again, they're very fragile and friable. So I think that is the last slide. So I've just jotted my contact details on the last slide, and obviously you'll share them, I'm sure. If there is anything you want to ask me that you don't feel you can ask me in the kind of discussion bit in a minute, please just drop me an email. I'll either phone you or I'll email you back, but hopefully you'll feel comfortable enough to ask in the question and answer section. We'll just move on to now. Thank you, Caroline.
Thank you, Sally. Really interesting presentation. Lots of information there, and learned lots of things. Personally, I've learned a lot of things I didn't know. So yeah, thank you for that. I hope other people found it really interesting and useful as well. Has anyone got any questions they'd like to ask Sally? Either you can pop it in the chat or you can pop your hand up.